Hi, welcome everyone to our webinar tonight. I'm just going to give it just about a minute just to let everyone kind of come on, and then we'll kick off. It's great. Now you see all the numbers building up. Okay, great. So I think we'll start to kick off. So thanks very much for coming tonight, everyone, especially on this kind of cold, windy, what is it, Wednesday afternoon. Sorry, so hard to know sometimes. So Dr. Hala is going to give a presentation just on fertility, kind of the testings and the causes of infertility, and then kind of going into the treatment options. If you have any questions or anything like that, please pop them into the Q&A box there and we'll go through them at the end. Don't use the chat box, just try to use the Q&A box. It's just easier for us to go through the questions. And anything I can answer, I will during the webinar. I'll be on in the background. But yeah, I hope you get something from this tonight, and I'll hand you over to Dr. Hala.
Hello, this is Dr. Hala Gomaa, fertility specialist, SIMS IVF Center. Today I'll talk about infertility, causes of infertility, investigations, options of treatment. What is infertility? What does that mean, infertility? Infertility means failure to conceive after 1 year of trial, 1 year of unprotected intercourse. The incidence of infertility about 15%, 1 to 6 or 1 to 7 of couples. Infertility could be primary infertility, never been pregnant, or secondary infertility. It means previous pregnancy, whatever. Successful pregnancy with delivery, a previous ectopic pregnancy, miscarriage, it is considered secondary infertility. There is difference between infertility and the subfertility. Subfertility, it means delayed conception, but it could be, the reason could be fixed. Infertility, it means zero chance to have a child from the patient own gametes or own DNA. In nature, how much is the cumulative pregnancy rate? If we have 100 normal couples, no problems, everything is okay, ovulation normal, open fallopian tubes, no male factor, how many of them will achieve pregnancy within 1 year? Usually, in younger age group, younger than 35, the rate is higher. But in general, cumulative pregnancy rate after 1 year is 85% of trying. Second year, half of the remaining will be pregnant without any help. It means almost 95% will be pregnant by the end of second year. Third year, this rate declines to be just 3%. Many factors affecting pregnancy rate. One of them, and the most important, is the female age. Age matters. As a female, we are born with a limited number of eggs. When we are getting older, both quantity and the quality of eggs decline. And this graph, it was published in 2004. That's why maybe this terminology has been changed. But this graph shows the fertility rate declines by age. And on the other hand, the miscarriage rate increased. And it is almost 90% after age of 45. Almost 50% of pregnancies end up in miscarriage around age of 40. When we talk about causes of infertility, I'd like to just in brief how pregnancy happens in nature. To have a normal, healthy pregnancy, when the egg released from the ovary, picked by the fallopian tube, the sperm meets the egg inside the fallopian tube. After 5 days, or almost 5 days of fertilization, the fertilized egg moves to be implanted inside the endometrial cavity. That's why to have a pregnancy, you need to have good quality egg, normal open fallopian tube, normal endometrial cavity, and good quality sperm. Causes of infertility could be related to male factor or female factor. Male factor almost 30% of the reasons, and the combined male and female almost 10%. Female factor 30%, it could be ovarian, tubal, endometriosis, unexplained infertility after we do everything. Everything came back normal, nothing. Open tubes, normal ovulation. Male factor rolled out. At that time, we define it as unexplained infertility or idiopathic. Unexplained, it means up to our knowledge. Maybe there is reasons, but we don't know. Maybe undiagnosed endometriosis, problem in implantation. Yes, fallopian tube, both fallopian tubes look open, but functionally it is not functioning well. It can't pick up the egg. To know the reason of infertility, for sure, investigations should be done for couple, male and female. Baseline investigation for male, just semen analysis. It is the basic, very simple. We advise the partner no ejaculation for 3 to 5 days. Semen analysis according to the WHO organization in 2010. To be normal, volume should be 1.5 milliliter or more. Count or concentration should be 15 million per milliliter or more. The total number in the whole sample should be more than 39 million. Total motility should be more than 40%. Morphology, it means normal shapes. Rate of normal should be more than 4%. After that, we may require further investigations. If there is any problem, like we can't find the sperm in the sample, sometimes we need to repeat it once more to confirm the diagnosis. If it is low number or low motility, we may need more investigations, blood work, hormones, ultrasound, to confirm the diagnosis. For females, we need more investigations. We do blood work, and we need also to examine the endometrial cavity. We need to examine the fallopian tubes. Blood work mainly to check ovulation and thyroid function, and to be sure that in general health she is okay. In our clinic, we do what we call it female fertility profile. It includes thyroid function test, prolactin hormone, complete blood count, testosterone hormone, rubella to be sure that she is immune against rubella. Another test to see the tendency to have blood clots or coagulability. Some clinics, they do another test, hormonal profile on day 2 or 3. It's called the FSH hormone. And the others, they do on day 21st, the progesterone hormone to confirm ovulation. Besides this blood work, we do also anti-Mullerian hormone, AMH. What is AMH? AMH, it is a marker for ovarian reserve. It is protein secreted by small follicles stopped in the ovaries. Anti-Mullerian hormone can be done any day of the cycle. Sometimes, if you are on oral contraceptive pills, it may be fall slow. That's why usually we advise to stop the pills before doing this test. Anti-malarial hormone can tell me about the reserve quantity, but not the quality. It doesn't predict pregnancy rate. It doesn't predict live birth rate, but it predicts the ovarian reserve and approximately like how many eggs will be recruited with IVF cycle. Another test for ovarian reserve, ultrasound scan. We check the ovaries. We check number of small antral follicles between 2 millimeter to 10 millimeter. We combine both numbers, antral follicles plus AMH. It helps us to define if you are good responder, normal responder, or poor responder. Usually, if antral follicles number less than 4, we consider it poor responder or poor ovarian reserve. More than 20, high responder or high ovarian reserve, and it is mainly in polycystic ovarian disease. Anti-malarial hormone, if it is less than 1 becomon, it is very poor. If it is more than 25, we expect high response. Actually, it is very important to know the ovarian reserve before proceeding for IVF. It helps us to choose the protocol for induction of ovulation to be within safe window, because there is window between no response and over response. To choose the protocol, medication, and the dose of medication. But again, it doesn't predict the quality of eggs. However, we expect good quality in younger age group. If I have two females with the same AMH number, one of them 32 years old and the other is 42 years old, the prognosis for sure much better in the younger one. Anatomical testing. Again, fertilization happens in the fallopian tube. And after that, this fertilized egg needs empty, normal endometrial cavity, receptive lining to grow in. To assess the tubes if it is open or blocked, first of all, history is very important. Usually I ask about the medical history first visit, detailed history. Ask about any previous surgeries, pelvic surgeries, any history of sexually transmitted infection, any history of ectopic pregnancy. Because some risk factors could increase the risk of scarring tissue around the tubes and tubal block, like history of endometriosis, history of chlamydia and gonorrhea. To test the tubes, we have many tests. First one, it is done in the clinic, and it is called SIS or hycosi. Because by regular ultrasound, I can't see inside the endometrial cavity and I can't see the tubes. We inject the fluid through very fine catheter. It's just a line to separate the walls of the uterus. And as you see, when we separate the walls of the uterus, we could see inside. To rule out any polyp, fibroid could interfere with normal pregnancy. And at the same time, rule out also any congenital anomalies like septum, bicornice uterus. And after that, we inject a white gel. It is hypoallergic to see if this gel came out from tubes. It means tubes are open. If it is stopped at any point, it means there is most probably it is tubal block. It is not confirmatory 100%. Sometimes it is just spasm at the time of the procedure. That's why I can't see the fluid. The fluid came out from one of the tubes. Usually we do this test in the first half of the cycle, between cycle day 6 and 10, for many reasons. First, to rule out pregnancy, because you never know, you may be pregnant anytime, and when I inject this fluid, it will disturb pregnancy. Also, because after ovulation, lining of the uterus will be thick lining. It will be difficult to distend the endometrial cavity. The other test, it is called hysterosalpingogram. It is done in the hospital, guided by X-ray. It is dye test. We inject the dye, the same idea, but the difference, it is guided by X-ray. It is more accurate for tubes, but SIS and hycosis more accurate for endometrial cavity. What about laparoscopy? Laparoscopy is the gold standard to diagnose tubal patency. And sometimes we recommend the laparoscopy if there is comorbidity. Someone, she had history of endometriosis, history of sexually transmitted infection. I expect scarring tissue. I recommend the laparoscopy. And the good point in laparoscopy, if there is any endometriosis, it could be like curative at the same time. You could do excision for endometriosis, but it is not recommended for everyone, for special cases, because it is invasive, it is surgery, keyhole surgery. That's why it is not the baseline to start with, except if there is another comorbidity. The other anatomical testing is hysteroscopy. What is hysteroscopy? It is camera through cervical opening. We inject the fluid, but it is done in the hospital, not in our clinic. Sometimes we refer our patient for hysteroscopy. Guided by this camera, we can have a look inside the endometrial cavity, and at the same time, if there is any scarring tissue, any polyp, any small fibroid, we can take it out to clear the endometrial cavity from inside. Other tests could be done. Blood work, it is called Chicago blood work to see natural killer cells in blood, T helper cells. It is not recommended by Royal College, but sometimes we do it for recurrent miscarriages or recurrent implantation failure. Natural killer cells, either in the blood or in endometrial biopsy. Uterine biopsy, it is not the baseline or first step for someone with primary or secondary infertility, but sometimes we recommend it in cases of recurrent miscarriages to roll out natural killer cells or inflammatory cells in the lining of the uterus. Sometimes we recommend it with recurrent implantation failure to see endometrial receptivity and window of implantation with the progesterone. Other tests, autoimmune testing for thyroid antibodies or other autoimmune like antinuclear antibodies in cases of recurrent miscarriages. Recurrent miscarriage investigations, bunch of investigations. It depends if it is this miscarriage, how many times, and the same partner or different partner, and if it happens in the first trimester or second trimester. It includes blood work, karyotyping, thrombophilia, antiphospholipid syndrome, and anatomical as well to roll out any problem inside the endometrial cavity, karyotyping for both parents. Endometrial function test, as I said, it is ERA for endometrial receptivity, genetic testing, karyotyping, mainly for recurrent miscarriages. Now, what is the advice if you want to increase your chances to get pregnant spontaneous on your own? Lifestyle. Smoking. Yes, smoking, very bad effect on both ovulation, eggs, and sperm. Very bad. The first advice for any smoker wants pregnancy, please quit smoking. Smoking affected like quality of egg and in very bad way, and sperm as well. But in sperm, if the male partner quits smoking, quality of sperm could be improved within 3 months. And what about alcohol? Data about alcohol is very conflicting data. Usually, if it is too much alcohol for males, it could affect erectile function and it could affect ejaculation. And for females, It could be like high dose of alcohol. No safe dose with pregnancy. Any amount of alcohol could be toxic to fetus. That's why we advise, if you want to get pregnant, you may be pregnant anytime, please don't drink. Coffee in moderate amount, just 1 to 2 cups per day, that's fine. It doesn't affect fertility. Exercise. It is very important because it increases endorphins, it relieves stress, and keeps you in good shape. What about stress? It is data about stress, very conflicting data. Unclear. For sure, fertility causes anxiety and depression. But does stress affect fertility? Many studies done. Because of stress hormones could affect hormones secreted from brain to stimulate ovulation, could be, but no confirmatory data. Does it affect IVF outcome? The data is unclear. But usually we advise try meditation, try relaxation technique, try to talk to someone like friend or supportive family or supportive partner. It is easy said than done, but we advise always just try. What about weight? Very, very important to maintain healthy body weight. We don't want too thin or too obese. Both are not good. It could affect response to medications, to injections, and also miscarriages. Yes, overweight and underweight. That's why to keep healthy within normal weight, it is very important. Now, after we discussed the causes and investigations, what about options of treatment? For sure, treatment based on the reason. But what if it is unexplained? I did everything is normal, no issues. At that time, we could advise timed intercourse if the couple are trying for 1 year and unexplained infertility, everything is normal, or very mild endometriosis, at that time we could advise you could try another year, timed sexual intercourse. What does that mean, timed sexual intercourse? We expect the fertility period 60 days and ended on the day of ovulation. Egg lives about 12 to 24 hours. We advise just have unprotected intercourse 2 to 3 times a week around time of ovulation. I don't highly recommend ovulatory kits because it could increase the stress. Sometimes we prescribe medications to regulate ovulation and to recruit eggs with intercourse. It is a good option within, as I said, if unexplained, for another year to be total 2 years. With induction of ovulation, it is option for patients with polycystic ovarian disease or ovulatory reason. She has like hypothalamic reason, she needs hormones to induce ovulation. At that time, this is one of the options. What if the patient, she has good ovulation? Should I give her induction for ovulation? No. I don't, like by guidelines, it is not recommended. If she has good ovulation, regular ovulation, don't give induction for ovulation to increase the chances of pregnancy. But she could try if she is young for another year. But if she is older, 36 years, 37 years, 40 years old, my advice, speed up as you can, okay? But this advice mainly for young age group, trying for 1 year, unexplained, or with ovulatory factor, and I can give her medication to regulate her ovulation. Second option is intrauterine insemination. Intrauterine insemination, by its name, I take the sperm, wash it, take the best swimmers, inject it inside the uterine cavity around time of ovulation. Still, fertilization happens inside the fallopian tube. That's why you need to have open tubes for IUI. What are the indications for IUI? IUI, the most patient can benefit from IUI who will use donor sperm. Either same-sex couple or single mothers and she wants to be pregnant, donor sperm. Mild male factor, we could try IUI. Unexplained infertility, it is not the guidelines, but sometimes we try that for unexplained infertility. And IUI could be on natural ovulation, we don't give any medications, or with medication to induce ovulation. What about success rate of IUI? It is variable, multifactorial. Most important factor, the maternal age, but in general, success rate about 12%. In general, it decreases when the female is older. Next step, next is the third option is in vitro fertilization, IVF. IVF, it means outside the human body. In vitro, outside the human body. Fertilization in the lab. We collect the eggs, take it outside the female body, give it to the lab, and either with the partner sperm or with the donor sperm, we fertilize these eggs in the lab. To do that, we give the female medications, injections, to recruit many eggs, to collect as many as we can. And we give the medication according to her history, previous response, her ovarian reserve, and she should come for a scan, for blood work to monitor. And when we see by ultrasound and the blood work, she has many good growing follicles. She is ready to trigger. We give her the trigger and we ask her to come for the collection day. We do the collection guided by ultrasound. There is needle connected to the ultrasound. We aspirate all fluid. It is done under conscious sedation. We give antibiotics for prophylaxis. There is low risk of infection, and there is uncommon risk of injury by this needle to blood vessel, bowel. Usually it doesn't happen because it is done under direct supervision. Other risk, we collect the eggs and no eggs. We collect, like we aspirate the fluid and we can't find eggs, or these eggs not fertilized. Another risk, at the time of medication, giving the injection, either no response or hyper response. But if we notice she has hyper response, at that time we like have special protocol to trigger, and also we don't transfer the embryo in the same cycle. We freeze the embryos and transfer it in another cycle. What happens after I collect the eggs? After I collect the eggs, and after the husband providing the sample or the donor sample, they fertilize these eggs in the lab by one of two ways. First way, it is just in vitro fertilization. Put the eggs and sperm in the dish, put it in incubator, have a look next day to see how many of them fertilized. The other one is ICSI, XZ, or intracytoplasmic sperm injection. I choose one motile sperm, inject it inside the egg under the microscope. What are the indications for IVF or XZ? IVF, if no male factor, if just a female factor like tubal block or unexplained infertility, mild endometriosis, at that time, and sperm is good quality, good number, good morphology, we go for IVF. If severe male factor, abnormal morphology, or we need to take the sperm by surgery, surgical aspiration from testicles, at that time it will be eggs. We expect fertilization rate usually around 80% fertilization rate of eggs, and pregnancy rate, success rate depends on the maternal age. We have our success rate published on our website. Younger than 35, the pregnancy rate about 50. Clinical pregnancy, it means ultrasound, and we see pulsating embryo. It is about 51.3%, and in frozen embryo transfer, 37.5%. Around age of 40, it declines to be 25.8%, and with frozen embryo transfer, 24.6%. Back to IVF, when we collect the eggs, fertilize it, put it in incubator for 5 days. On day 5, we have a look at the embryo under the microscope. At that day, we call it blastocyst. We score this blastocyst according to the shape, how good looking under the microscope. The blastocyst has inner cell mass and external cell mass. We give them score, and it depends on the fragmentation, the cells, everything. The highest AA or AB or BB, but the quality of blastocyst, it doesn't mean this embryo carries normal chromosomes. May be very good looking, but DNA material inside not normal. Chromosomes not normal, especially in older maternal age, older than 40 years old. As there is another procedure could be done. It is called pre-genetic screening. We do biopsy. We take few cells from the external cell mass from the trophoectoderm, about 5 to 6 cells, and we send it for special test for chromosomal analysis or karyotyping. As a normal female, I have 46XX. Any male, he has 46XY. The results come back either normal chromosomes or aneuploidy or abnormal. 5% of cases more results. Risk of damage for the embryo less than 1%. Accuracy about 95%. If it came back normal, 95% normal. Pre-genetic screening doesn't increase the pregnancy rate. It might decrease the miscarriage rate, and it decreases the number of unnecessary embryo transfer. Say I have 10 embryos, but only 3 or 4 of them normal. I avoid transferring 6 abnormal embryos. And what about in the treatment? Surgical sperm retrieval. Sometimes we need that in cases of the obstructive azoospermia. We do aspiration of the sperm. We retrieve the sperm from the testicles, or some cases with deletion, but it should be A, not B or C. We have either TC or micro-TC. Micro-TC, the recovery is higher than TC. What about donor egg? Donor egg, it is an option for patients either with poor quality eggs, can't make normal good embryo, or with patients with premature ovarian insufficiency, patient with previous removal of ovaries, whatever the reason. Unfortunately, so currently right now, the program in our clinic is on hold. We don't have a program right now. Hopefully, we have it shortly. But what happens if we have this program? The partner, we ship the partner sperm to the clinic, and the eggs is fertilized there. And after that, they ship the embryos back to our clinic, and we transfer one of these embryos inside the endometrial cavity. It is very successful because usually the donors young age with good egg quality. Another facility in our clinic, it is egg freezing for a social reason. Egg freezing could be an option for patients going for chemotherapy, radiotherapy. They will have premature ovarian insufficiency. They need to freeze their eggs, but it could be an option for non-medical reason, for social reason. I don't have a partner right now, or I want to postpone pregnancy, whatever the reasons, and I want to be pregnant from my own eggs when I am ready to do that. Egg freezing, the same idea like IVF. We will give medication to recruit eggs, collect these eggs, and we freeze the eggs. What about the success rate of egg freezing? First of all, egg freezing is valid for 10 years. You should use these eggs within 10 years. Second, it depends on the age at time eggs were collected. Younger is better. Survival rate of eggs after thawing about 80%, and fertilization rate about 79%. Live birth rate in young age younger than 36 about 4% from each egg. It means, like, if I have higher number frozen, it is better. More is better. Our aim around 24 eggs to be frozen. Sometimes I can't collect all this number in 1 or 2 cycles. You may need more cycles. And when you are getting older, you need to freeze more to have a good success rate. Around age of 40, you need more than 24, more than that. Also, I want to talk about embryo freezing. When I spoke about IVF, and after I have the embryos, if it is fresh embryo transfer, we will transfer only one embryo inside the endometrial cavity, and the rest we will keep them frozen. It is very safe. We have new technique. It is called vitrification technique for freezing. And anytime, if the first cycle was not successful, we can use one of these embryos, and you don't need to repeat the whole IVF cycle, just frozen embryo transfer cycle. Or if you get pregnant, you give birth and you want another pregnancy, you come again for another frozen embryo transfer cycle. It could be an option, like if you have a partner, you are not ready for pregnancy right now, you can freeze the embryos and use it later. But at that time, it will be both of you. You can't use it without his permission. But your eggs, it is your eggs. You can use it anytime, either with the current partner, future partner, or donor sperm. It is your eggs. What about the cost of treatment? Cost is not only money. Yes, it is expensive, but at the same time, physical, you should come to the clinic for monitoring, ultrasound, blood work, giving injections, discomfort from injections, emotional for sure, psychological stress, yes. But once it is successful and you achieve your dream, you will be very happy, and that's it. Yeah. I wish it was clear, and please let me know if you have any questions. I am happy to answer.
Hey, Hala, we have some questions here anyway, so I can start off one of them here. Just could you talk a little bit more about fertility and endometriosis? Just how that affects, if you have endometriosis, how that affects you.
Yeah, fertility and endometriosis. Yeah. What is endometriosis? Endometriosis is immigration of the lining of the uterus outside the endometrial cavity. What happens every month? when you have your period shedding of the endometrial lining, it happens the same in these spots. It could be in the ovaries, we call it endometrioma. It could be in the pelvic cavity. It could be inside the wall of uterine muscles. We call it adenomyosis. The main, it depends management of endometriosis. What do you want to do? If your main issue is pain and discomfort, pelvic pain, or you want to get pregnant. And it depends on the stage of endometriosis. Endometriosis for sure can cause scarring tissue around the tubes, can cause tubal obstruction, can cause change in the immunology of the lining of the uterus. We could refer here for laparoscopy for excision of endometriosis. Medical treatment, not an option. Treatment of endometriosis could be medical or surgical. Medical treatment, sometimes we give injections to suppress all hormones, to prevent ovulation because endometriosis feeds on estrogen. It could be one of the options, but it is mainly if the complaint is pelvic pain. But for fertility reason, it depends on the size and the stage of endometriosis. Either we refer for laparoscopy and after that IVF. If it is mild endometriosis and young patient, first year of trying, she could try 1 year more or with IUI. But after that, next step will be IVF. And again, it depends on the stage of endometriosis. Sometimes we refer first for laparoscopy for excision of endometriosis. And after that, we do the IVF.
Okay, perfect. And then there's just another one, how long do you refrain from sex before semen analysis?
3 to 5 days. We advise no ejaculation 3 to 5 days before the semen analysis.
Fantastic. Is it possible if a man has Klinefelter syndrome to father his own child?
Yes, we can do surgical retrieval of sperm, but at that time, the children, they may have a risk. That's why we prefer to do pre-genetic screening for embryos.
Perfect. And what is the success rate of IUI?
In general, it is 12%, but around the age of 40, it is very low. It's almost 4%.
Okay.
And it depends on the maternal age, quality of the sperm. We need for successful IUI, after wash of the sperm, at least 5 million in the sample.
Okay. Would you recommend there's a better chance going straight into IVF instead of trying IUI?
It depends. If unexplained infertility for 2 years, for sure, guidelines said IVF right away. But sometimes if first year, like trying for 1 year and unexplained, the first year, like the second year, they could try either intercourse or IUIs. Mild male factor, mild endometriosis, we could recommend the IUI. And success rate only 12%. Some patients may prefer to save money for IUIs and to go ahead for IVF.
Yeah.
Again, IUI mainly very successful for donor sperm.
Okay.
Either same-sex couple or single mothers. It is the most successful.
Okay. Would transferring a blastocyst day 5 increase your chances of success instead of maybe, I think they mean a day 3?
Yes, many studies done. It showed blastocyst on day 5 success rate much better than day 3. First, because if the embryo survives to day 5 in the lab, it means good quality embryo. Second, it is more physiological because in nature, it takes 5 days for fertilized egg to be implanted inside the endometrial cavity. That's why the window of implantation, when we transfer on day 5, it is window of implantation with the progesterone.
Yeah. So there's just a person asking, is there a waiting list for the clinic at the moment? There is in our Clonski clinic. There is about I think about a 4 to 6 week waiting list in regards to getting initial consult. Yeah, more slightly
3
longer in our
months.
yeah, and then swords is slightly longer as well. So yeah, there is a little bit of a waiting list at the moment, but I would just say just go onto their website, request an appointment, fill out our new patient form, and you know if there is any cancellations or anything like that, we'll get you on the list. But yeah, no, definitely just submit your patient form, and we will get you there. There's another question on average: how many cycles are needed before getting pregnant?
How many cycles before getting pregnant?
Yeah, it's a bit of a
How free
yeah.
from the first cycle? Again, success rate depends on many factors.
Yeah.
Age, endometrial receptivity, but usually in young age, maybe from the first cycle, it will be successful. And by the way, more unsuccessful cycle, less prognosis.
Yeah, that's good. So there's a few cost ones here, which I can kind of send on the details of our price list afterwards, because it's kind of, the cost is quite specific to your treatment and what you need to kind of get through. So it's kind of a hard one to give an average costing. So I can definitely go into, I can send on a price list or a link to our price list at the end. So someone's asking about how does IVF work with polycystic ovaries?
Polycystic ovarian disease,
Yeah.
we divide it either insulin resistant or non-insulin resistant. It is very important to know complete medical history, hair weight, other hormones, and other factors to be sure that fallopian tubes are open, male factor rolled out. It depends on her age. Sometimes we recommend just medication to regulate her ovulation, either tablets or injections, timed intercourse. We add sometimes metformin if she has insulin resistant. If it is not successful, next step will be in vitro fertilization. It is one of the indications for in vitro fertilization. The problem in PCO, the window between no response and overstimulation or hyper response is very narrow. That's why we will be very conservative, when we prescribe usually the protocol for young patient with PCO, it is short antagonist, and it is the success rate is very good in young age group, very good. Just she has good response, good quality, it is very good. But again, age of the patient, body mass index. Usually I do for PCO patient fasting insulin, fasting blood sugar to see if she has insulin resistance or no. Other hormones like prolactin and TSH, testosterone, roll out all other factors of infertility. Options of treatment depends on if there is any other factors. Could be just medications to regulate her ovulation. And by the way, success rate is very good with just tablets or either ovulation or getting pregnant. Second, with metformin or without metformin. Second step, if open tubes, everything is fine, we could try IUI. Third step, it is IVF. And our aim to avoid multiple pregnancy. The problem in PCO, when I give induction, I don't want many eggs because she has very high ovarian reserve. She may have hyper response. That's why the risk of multiple pregnancy is very high. IVF is good because I could transfer only one embryo, single embryo at a time, to avoid this problem.
Very good, lots of information there. Would you recommend acupuncture during treatment?
No harm to do acupuncture, but no evidence-based medicine to do it. It could help for meditation, to relax, but that is not clear if it is beneficial to improve the IVF outcome. But for sure, it could help to relieve the stress.
Okay, very good. Oh, sorry, I'm just looking at some of the questions here. Some of them are quite specific, so we're not going to be able to answer all of the questions here, but you can definitely send on questions to communications@sims.ie and we can answer them offline. So this one is IVF always the first option trying to conceive for 10 months and the AMH is 7.79. and
How
she's
old is she?
35. She's 35.
She's 35, and her AMH how much?
7.79.
And like,
I'm trying
what
for
about
10 months.
for how long she is trying for pregnancy?
10 months.
10 months only?
Hmm.
And any what about male factor?
There she
Fallopian
didn't say.
tubes?
Nothing said. No, she hasn't said.
Yes. Again, AMH alone doesn't predict pregnancy, doesn't predict labors. 7.79 is low for her age, but what about number of antral follicles? What about all other factors?
Yeah.
I need to combine this number with antral follicles number. I need to see other factors to see if we need to speed up to go ahead for IVF or just IUI. It depends on other factors. AMH alone, it is just quantitative, but I need everything else like. And 10 months for 35 years old. Usually we recommend 1 year around 35 of trying, but if she has known problem, she is known to have diminished ovarian reserve or known to have polycystic ovarian disease, known to have an issue, she could ask medical advice before the 1 year.
Yeah, I think so, yeah.
Or older than 36 for sure. She should ask medical advice less than 6 months, within 6 months.
Yeah. Okay, perfect. Do you recommend not doing IVF if you have a high BMI?
How much is the BMI? If more than 40, usually I recommend to go for bariatric surgery first. I recommend that, but I know the waiting list is very long.
Yeah.
That's why sometimes we don't wait. We try our best to choose safe medication. Again, body weight is very important for responsive medication to decrease the risk of miscarriage. Body mass index more than 40, usually I recommend bariatric surgery. And to get pregnant, the recommendation is 1 year after bariatric surgery.
Okay, thank you. What are the costs of basic tests which can be done before IVF? Well, we do have a fertility testing package for men and women. So it's just the kind of, you get the semen analysis done and then you get your AMH, I think it's your thyroid and your prolactin checked, and that's €300 for a couple. So that's definitely a good one to go for. We have a low AMH and sperm and a low sperm count due to undescended testicle, and that was detected late. Is there any point in having ICSI? Age 37 and my hubby is 39.
Female partner is 37?
Yeah.
And the male is 39?
Yeah.
And he has azoospermia?
Yeah, like it just says a low sperm count, so yeah.
Low sperm count or azoospermia? Because low sperm count, we can do ICSI with this sperm. What about the motility, morphology, and her AMH? Again, just number. How much is the number? How is the antral follicle number? We combine both together.
Yeah, so yeah, definitely it's definitely
the data is not enough data.
Yeah, you need, I suppose, definitely to come in and just seek our advice and to get some testing done.
I need to have a look at the semen analysis, have a look, everything, antral follicle number, AMH, and at that time I decide what is the best option.
Yeah, exactly.
Does it worth to go for IVF and pay for IVF? Sometimes I advise no. Prognosis is not good. Just save your money for egg donor or double donation. But I can't say just low AMH, low count, it works, or I can't say that.
Yeah. What solution would you recommend for someone who's gone into early menopause?
Early menopause. Early menopause, it is not, early menopause 1% in population. There is difference between premature ovarian insufficiency and early menopause. Premature ovarian insufficiency, younger than age of 40. But early menopause, between age of early menopause is different because menopause, it means no eggs at all. I am 100% sure no eggs. She is menopausal. But that's why we changed the terminology to be premature ovarian insufficiency. She may have sporadic ovulation. The problem in premature ovarian insufficiency, she needs hormones. It's not only pregnancy. Like ovulation and the eggs, not only for pregnancy. As a female, I need this estrogen hormone, especially in young age group, for protection of bones from osteoporosis, from heart disease. Any patient with very high FSH and she has premature ovarian insufficiency younger than 40, we should do a bunch of investigations to know the reason of premature ovarian insufficiency. It could be genetic. Sometimes it runs in familial, and it could be autoimmune disease. That's why we do anti-adrenal antibodies, anti-thyroid antibodies. It could be secondary to chemotherapy, radiotherapy. Sometimes it is idiopathic, and it is 1% of population. Spontaneous pregnancy could happen 5 to 6% in patients with premature ovarian insufficiency. She may have sporadic ovulation, but it is not the standard. She should be on hormone replacement therapy for her general health, to protect her bones, to protect her heart, and she should have monitor bone density to see that to rule out osteoporosis. That's why early menopause, premature ovarian insufficiency, regardless she wants pregnancy or no, she should have special care. For pregnancy, the best option will be egg donation. The best option. We will give her hormone replacement therapy to build up the lining of the uterus to accept the embryo. It is the best option. But we need to know what is the reason for premature ovarian insufficiency, and the best treatment is hormone replacement therapy.
Yeah, that's some great information there. So this one is an SIS painful?
Excuse me?
Is an SIS painful?
Yes. Because of distension of uterine cavity by fluid, you may have cramps same like period. We are individual. Pain threshold is different from 1 to 1. 99% of patients they can tolerate with simple painkiller, Advil, Tylenol, 30 minutes before the procedure. But few patients they may need conscious sedation at the time of SIS.
Okay. Is it better to have unprotected sex every day rather than 2 or 3 times a week to increase chances of conceiving?
We advise 2 to 3 times a week is enough. But if you if you want every day, it's something up to you. But our advice 2 to 3 times a week around time of ovulation.
Yeah. Sorry, now I'm just flicking through. There's a lot of questions here. So like I said, we won't be able to get through them now because we have 2 minutes left. So I'm just trying to see now. What is the price of a first consultation? It's €180. So yeah, there's a lot of quite specific questions here, so that we can definitely answer these offline because they are quite specific to certain people's treatment. So I think we'll just wrap it up now because we are nearly at 7 o'clock now. And so I just want to thank everyone so much for attending the webinar tonight. I will send on some information. You can contact me through communications@sims.ie, and I will go back and try and answer some of those questions that we didn't get through to tonight. So thank you very much, Dr. Hala, as well for your time.
Thank you, and thank you very much.
Thank you. And yeah, it's been thanks to everyone for being so engaged and involved in there. And we hope that we answered some of your questions tonight. Okay. Thank you so much.
Thank you very much for your time.
Bye.
Thank you. Bye-bye.
Bye.
Have a